Hello, it's a pleasure to be here, and I've learned a huge amount from working with my JPAL colleagues, including Marianne and Kate, and it's just been a delight to be here today. It's not my typical world. I'm a policy person. I'm in DC a lot. It's a tough place to be right now, so I sort of decided to just take a little moment to enjoy learning and talking and go back to the fights tomorrow. So I'm going to talk a little bit about nurse-family partnership, and I'd like to start with the motivation for creating the program and just the story of how it came to be. It was David Olds is our founder. I think most of you probably know about him, and he was working in an inner-city daycare center in Baltimore, actually where The Wire was filmed, if you've seen The Wire, and obviously found that a lot of the 3-, 4-, and 5-year-olds he was working with were suffering from things that could have been prevented with a program had it started earlier during pregnancy. And so he really focused on, he used a number of psychological theories to create this program, and it has 3 program goals. Simple: improve pregnancy outcomes, improve child health and development, and to improve parents' economic self-sufficiency. The program starts with the clients we focus on first-time, high-risk moms. We work with nurses, because nurses, we have been told actually, and we've done surveys recently interviewing the moms and asking them why. Why do you, what do nurses give you? What's the most important thing about it? And it's the care, the information, and the advice that they're able to receive based on the relationship that is established between the mom and the nurse. So NFP is a relationship-based program, and I'm going to say it a couple of times because it makes all the difference in achieving the outcomes. It's intensive. We start early in pregnancy before the 28th week, and we go until the child is 2, with visits that are generally every 2 weeks, more intensive around the birth and less intensive towards the end. And it's timely. As this crowd knows, the first 1,000 days starting in pregnancy are very important from a scientific point of view. I just pulled out notes that it's 700 to 1,000 new neural connections form every second. After this period of rapid proliferation, connections are reduced through the pruning process, and it allows the brain development to become more efficient. So and I think you'll recognize this slide. This is from Jack Shonkoff's Neurons to Neighborhoods. This slide just shows that NFP works in the period, the 30-month period where much of the vision, hearing, and language development occurs. The foundation of NFP is really in the randomized control trial work that was done by David Olds and colleagues. And I want to note that Robert Wood Johnson, if you're still here, really was very important in providing the funding in almost a visionary way to allow Dr. Olds to do these trials over time. It's hard money to come by. Again, I think this crowd understands that. And so there were 3 trials that were conducted, and the model and the implementation process, and I was really fascinated by the whole conversation around implementation research, because we're spending a lot of time thinking about implementation as well, but both the model and the implementation are a work in progress. And we are partnering with Hope Lab right now on some model modernization work that will be tested in the evaluation in South Carolina, which is very exciting. But I'll say that broadly, I think NFP is one story of science to practice. Our national office that I work for was created in 2003 in order to support communities in implementing this program with fidelity. And so we began in 2004 to speak intentionally to government about making this program available, and we were successful, fortunately, early on in getting some money for that. One anecdote I think is worth mentioning is after the results from the Elmira trial that were very positive and unexpectedly positive around reduction of child abuse and neglect, and also criminal justice, involvement with the criminal justice system, Dr. Olds met with then Senator Kennedy, who was interested in taking those results and creating a program and scaling it nationally. And based on the sense that it wasn't enough data to be confident that this program would be effective everywhere and with different communities, that opportunity was declined. It was a thank you, Senator, but not now, because we need more data on whether this program really makes a difference in other communities and with different populations. So that work went forward. Now, I'm just going to go quickly through the next 4 slides that I'm offering simply as an illustration of a few key points in the narrative on evidence-based policy as it applies to home visiting. The Coalition for Evidence-Based Policy was created. It now actually lives in the Laura and John Arnold Foundation, mentioned as a funder of another, in Amy's slides, I think it was mentioned as an important funder. So this coalition was really important in DC in starting to talk about evidence and making it accessible to policymakers. So they did a lot of work in ranking programs based on what they call their tier standard. We were glad that NFP was identified as a top-tier program, but they really have focused a lot of time educating policymakers about what evidence is. It's hard on the Hill. You have 10 minutes talking to somebody. The kind of conversation that we're having here today is not something you can do in 10 minutes or half an hour, and so John Barron at the Coalition has been instrumental in helping congressional members of Congress and their staff become more facile in deciding what's important to talk about with evidence, and also in informing the structure of new programs that are created. So that's one important piece of work that was done. He was helpful to us in getting money from the Bush administration for evidence-based home visiting in 2005. And then in the Obama administration, that was really expanded with the creation of the Maternal, Infant, and Early Childhood Home Visiting Program as part of the Affordable Care Act. Fortunately, we were able to move that out of the Affordable Care Act into something called the deficit reduction, onto the doc fix, and we are living with sort of congressional counsel right now trying to figure out exactly what will happen when and if there is a partial or full repeal of the ACA. So we'll see. But one of the other things that happened along the way was that mainstream and influential media started talking about this stuff. So people like Nick Kristof, David Brooks, they started really sounding the drumbeat about evidence and why it should matter and why government should think about it, and we are very grateful to them. There was I don't know if you guys have you heard of the Moneyball for Government campaign? Yeah, I've got some nods here. So this was created in 2013, and it comes from a world I know nothing about, from the sports world. The Major League Baseball, and I'm looking down at my notes on this, Billy Beane was the legendary general. Does anybody know? Legendary general manager of the Oakland Athletics, and he used data and statistics to overcome amazing financial disadvantage. So I know nothing about this world, but he was very successful. And then a bunch of smart people in DC created this thing called Moneyball for Government, and they brought together very important Republican and Democratic leaders to say this makes a difference. Let's do these 3 things. Government needs to figure out what works, and this room really matters in telling government what works and what doesn't. Once we know what works, government needs to shift dollars in that direction. That's a really hard thing to do. I spend my life doing it. It's very hard. And we want to partner with you on making that understandable to them. And finally, we need to stop funding what doesn't work. That's a long goal. We'll find out if that can happen. Ron Haskins is somebody at the Brookings Institution who comes from a Republican background on the Hill. He's been an incredibly forceful policy voice, and my hope, I don't know, will be that he will be able to be relied on in this new policy context we have, because he is identified as a strong Republican. So I'm hoping he will still be in the room, and he has really worked on that 3rd prong of the Moneyball for Government campaign to try to push funding away from things that don't work and direct funding to more things that do work. So he's been amazing. So these are just examples of people who've played a really influential role from the place I sit in the policy world around home visiting, and they're notable. So I'll talk now about the project. I'll turn to a little bit to talk about the project that we are working on with JPAL in South Carolina. And I'll say that Pay for Success, we see Pay for Success as the next iteration in evidence-based policy. And in its most simple form, it's simply a 3-way contract between investors or philanthropy who put up the money up front for an organization to deliver a service, the provider who delivers the service, and the government who agrees to pay back the investors for the money if and when the provider hits outcome metrics as determined by an independent third-party evaluator. So there are 4 parties, but 3 parties to the contract. We have hope that PFS can help increase a focus on evidence and outcomes, and that's a great thing. And it may help to address the wrong pocket problem. So for NFP and other providers, one agency pays for the service and another agency gets the savings, and that doesn't work. With PFS, it's driven by the executive in a state. It's always out of the governor's office, and so you overcome the wrong pocket problem theoretically. And also you can overcome the 1 to 2 year budget cycle problems and the 4-year election cycle so that you can hopefully have longer term planning that allows for investing in prevention over the long term. With the South Carolina project, there are a couple of things I want to say that are really important. First of all, we were in South Carolina with philanthropy funding only. Pay for Success created an opportunity to leverage that to secure federal money as part of a waiver and state money as part of the Medicaid as well. There's a federal state match for Medicaid. We also took advantage of an opportunity to, with the RCT, to modernize the model. So we are testing whether we can achieve the same outcomes at a lower cost. And so JPAL's role in that is essential, and we'll be talking through some of the challenges of that together, but that's very important to us. I'll say one thing that really remains as a question, and it's a very important question for us with Pay for Success, is right now state governments have not committed to sustain the services even if the outcomes have been met, the payment metrics have been met. And for the amount of work that providers have to go through to be part of a Pay for Success project, it doesn't seem like it's a rational use of time to go through it unless there is a state willingness to continue funding if outcome metrics have been met. So I think it's the next evolution in whether Pay for Success can work, and I think there are real questions about whether Pay for Success and RCTs are the best place to learn about what works and what doesn't, because there are pressures that come from Pay for Success, like enrollment metrics that cannot be delayed because there are costs associated with slowing enrollment. And in RCT, you want to make sure you're getting the right group into that study so that you can truly determine the benefits of the program. So all of this is to be determined, and I think JPAL and NFP and the private funders and the state all sort of took a leap of faith and said, we'll work this out going forward. It's a very complicated and exciting project, but more remains to be seen. Thank you.